Good morning. I'm Dr. Ken Kaiser, and I'm pleased to be here and participate in this virtual symposium. I want to compliment the organizers for putting this together and taking a new approach, if you will. I was asked to talk about the future, and I recognize that this is a radiology symposium, but I'm not going to say much about radiology per se. My assignment was to talk about the future healthcare system in which radiology programs will be functioning in, and some of the attributes and design characteristics of the healthcare system of the future in which radiology will be an integral component. Basically, what I would like to do in the time that I have is three things. I want to very briefly highlight why we have to move from where we are to what are characterized as high-performing healthcare systems. I want to then shift and talk about the evolving concept of systemness in healthcare, and then review some of what we know today about the defining characteristics or defining functionalities of healthcare systemness, and in many ways provide a conceptual model for where healthcare is likely to go in the future. And I recognize that unlike many of the presentations in the symposium, which have very specific and concrete information that may be immediately usable, this is a more, perhaps a more ethereal or conceptual conversation, but nonetheless I think it's important to understand where we're going and where the healthcare system broadly and the healthcare environment of the future is likely to be focused. So with that, let me start with perhaps the most basic of observations, and that's simply that the future isn't what it used to be. And certainly over my many years in healthcare, that future has changed many times. But in noting this, this also is cause for much of the confusion and uncertainty and bewilderment and other sorts of things that exist today among providers as well as patients. Also in saying this, I should remind us that none of us generally like to change from where we have been. Indeed, the famous economist John Keynes made this point many decades ago when he observed that the idea of the future being different from the present is so repugnant to our conventional modes of thought and behavior that for most of us we offer great resistance in acting on it in practice. And I think we're seeing many demonstrations of that today in healthcare. So with that as a preface, why do we have to change? What's driving the healthcare system? And I'm only going to hit the high points here. I suspect this is information that is pretty well known. But there are a number of major drivers for why the healthcare system has to change. At the top of the list is simply the fact that healthcare is too costly and that the increases in healthcare costs are simply not sustainable, and that is perhaps at the root of so many of the changes that are being implemented. But it's also important to note that that's not the only thing, by no means the only thing. We also have a very underperforming healthcare system, and the evidence for this is quite robust, and whether we look at it from the perspective of deficiencies in quality, deficiencies in safety, in service, in a number of other areas. Overall, the healthcare system is underperforming, notwithstanding the fact that it does also some very good things. We, with this as context, it's also important to note that the demand for healthcare services is rising rapidly, in part driven by the aging of our population, in part driven by just growth in population, but also contributing this is just our ability to treat more conditions, the fact that chronic disease is becoming more prevalent, and there are other factors as well that are driving this increased demand for healthcare services, not the least of which is simply the explosive growth of technology and our ability to do so many more things compared to years past, certainly compared to when I was a resident or a house officer at UCSF quite a few years ago. And this creates a bit of a paradox, because at the same time that demand is going up, our ability to do more is increasing. There are also widespread shortages in the healthcare workforce. Physicians, nurses, pharmacists, physical therapists, imaging technologists, we can go down the list. There are widespread shortages currently. These are projected to, or they're likely to increase in the future. Indeed, here in California, we're looking at many of our counties likely to see 25% or more of the currently practicing physicians retire within the next 5 years, at the same time that there's going to be a significantly enlarged insured population, and the demand for services will be increasing. So this is going to create some tension at a minimum. I should also note that things like healthcare consumerism is driving change, that simply the product that's being produced by healthcare isn't meeting the needs of many people, as their ideas about what they want out of healthcare has changed. And perhaps the last thing to note on this quick overview of the list is simply that overall population health is not going in the right direction. Indeed, there are many indices now that show that overall population health is either stagnating or in many cases starting to deteriorate at the same time that costs continue to rise rapidly. And in that, within that context or background, as was noted by Keynes and others, there's a lot of vested interest in maintaining the status quo, but for many reasons that's simply just not possible going forward. So all eyes are focused today on the Patient Protection and Affordable Care Act that was enacted now 3 years ago. And some are asking, is this the end? Is this the end game? And the answer is no. As far-reaching and as many changes that are brought about by the Affordable Care Act, there's more to come. Unclear exactly when or where or the specifics, but the Affordable Care Act is a milestone, a major and very important milestone in the transformation of American healthcare, but there is more to come, particularly with regard to safety issues and economics and controlling the rise of healthcare costs. So one might ask, where is that all likely to go? And again, the crystal ball is cloudy, but I think the emerging concept certainly is that the future is about high-performing healthcare systems. And how do we get to what would be considered a high performance or a high performing healthcare system? There's increasing attention has been focused on trying to define what is a high performing healthcare system. The Institute of Medicine, the Commonwealth Fund, others have published reports and done work in this regard. And some of the attributes are, as shown on the slide here, that a high-performing health care system is focused on ensuring healthy and productive lives. It's driven by the 6 parameters that were defined in crossing the quality chasm as far as care being effective, safe, patient-centered, timely, equitable, and coordinated. Universal participation is another attribute, and while we're not there, we're certainly much closer to that with the Affordable Care Act than we were in years past. And finally, perhaps the other attribute that the IOM and others have associated with high-performing healthcare systems is this capacity to continuously learn and improve and innovate and get better. Now, there has been an attempt to try to look at the evidence. There was a Cochrane review published last year that did a meta-analysis of essentially all of the papers that have been written in this regard. And by and large, it's a qualitative literature. There's very little in the way of quantitative studies. Indeed, the only thing that, the only attribute that could be clearly linked quantitatively with a high-performing healthcare system was CPOE. There were a number of other things as far as workforce design and structure and financial considerations, other things. But by and large, the evidence for these things remains relatively soft at this time. Others have tried to define what is a high-performing healthcare system. The American Medical Group Association has defined these 7 domains of a high-performing healthcare system that are shown on this slide. And in the interest of time, I'm not going to go through them, but they mirror relatively closely with what has been found by others. Perhaps a more complex or sophisticated way of looking at it is the quality systems assessment that Kaiser Permanente uses, and which is depicted here in this 3-dimensional model, which looks at the 5 basic quality systems and 9 different areas within those, and then a number of ways of looking at evidence to define that. Again, in the interest of time, I'm not going to go into this model, but want to move forward to the where I'd like to spend the rest of this conversation, and that's really about this concept of systemness. And if we look at all that has been written and talked about as far as high performance, in many ways it all boils down to high performance being directly related to the degree to which an organization achieves systemness. This term systemness is not one that has been widely used in healthcare to date. And so the legitimate question would be, what is it? And recognizing that this is a radiology conference, this is my one slide that has any connection per se to radiology. But the systemness can be thought about in broad terms as referring to how well the components of an organization, viewing organizations as systems, how well those components collectively perform in achieving a common purpose. If we look at healthcare systems today, one of the first things that strikes us is how heterogeneous they are. But also when we look at them from a systemness perspective, it's also clear that most healthcare systems today don't demonstrate the tangible synergies from systematizing that one would hope for. Indeed, they demonstrate poor systemness. And increasing attention has started to be focused in the last year or so on trying to determine what is systemness? What does it mean? How do we achieve it? What are the attributes that one should be looking to? And I think illustrative of this, last November, ECRI sponsored a large conference in Washington, D.C. and brought together people from throughout the country to try to focus on this. Just ironically, at the same time, there was, or a couple weeks earlier, there was a conference in New York put on by or sponsored by the State University of New York. Education, or higher education, is also looking at this characteristic of systemness and seeing this as something that they need to focus on as well. And indeed, I was invited to speak at this conference from the perspective of what might higher education learn from healthcare as far as systemness. Unfortunately, it wasn't a long lecture in that regard. But at the ECRI conference, I was asked to define systemness, and this is how I did that. And I just want to call out a couple characteristics here that I think are important as we think about systemness going forward. Again, it refers to the degree to which the disparate or many parts of a system or an organization connect and how they are interconnected so that they behave as a coherent whole. And in doing that, they behave in ways that are distinctive from and different than the individual parts, and that they achieve predictable and consistent results that are superior to the sum of those parts. Indeed, there are tangible synergies from aligning the different parts together in a way that produces this coherent whole. So what do we know about healthcare systemness? What can we say about it today? There's a number of things we can say. The first, I think, and perhaps one of the more important points, is that achieving systemness is essential to both improving the quality of healthcare, improving the value of healthcare, and to the future financial sustainability of healthcare. In many ways, that we have to learn how to achieve systemness and these tangible synergies that so far have, by and large, eluded healthcare systems with a few exceptions. A second point that's perhaps worth noting is that systemness doesn't just happen. Systemness results from intentional design and then the execution of a strategy to achieve systemness. It's not something that inherently is going to happen. It does require thought, planning, and then execution on that plan. I think a third point that's important to understand is that achieving systemness in healthcare also has to be grounded on an understanding of how complex adaptive systems operate, recognizing that healthcare operates as a complex adaptive system. And it's fundamentally different, and indeed one might editorialize that one of the reasons why much of healthcare policy hasn't achieved the desired outcome is that it is using a more linear manufacturing model for how healthcare operates, and fundamentally it's the wrong model to think about healthcare. Now, having said that, how are complex adaptive systems different from more linear manufacturing type systems? Well, there's a number of ways, and I'm taking, I think in the spirit of intellectual honesty, I'm taking a few liberties here. They're There are some nuances of complexity theory that may not be quite appropriate here, but I think for our purposes it's reasonable. But perhaps the first thing to note about complex adaptive systems is that they are not linear, they're not static, and they tend not to reach fixed equilibrium points. They're continually changing. They're very dynamic. They're composed of independent agents whose needs and aspirations and goals aren't all the same. And those different goals and desires and behaviors tend to sometimes conflict, as we often see in healthcare, where the goals of hospitals and physicians and nurses and pharmacists and others may not all be exactly the same. Another key attribute here is that these independent agents are intelligent. They learn, so that the system behavior changes over time. Again, it's not static. It's continually adapting to changing circumstances. Perhaps the last and maybe the most important point here is that in a complex adaptive system, there is no single point of control. There's no one that is truly in charge. As a former CEO of a large healthcare system, I sometimes like to delude myself into thinking that I was in charge, but in reality, that's rarely, if ever, the case, and that's a fundamental attribute of a complex adaptive system like healthcare. But you might ask, what does that mean? It's important for how we think about changing the system, and it means that change can't be specified or controlled in the same way that you would in, again, a more linear system like manufacturing, where if you control one part, then you can have an expected outcome in the process going forward. The key to changing complex adaptive systems is identifying those key change levers, those few things that if one makes relatively minor or modest changes in them is likely to have a magnifying effect throughout the system that will produce the desired change. Ideally, in doing that, one looks at change levers or strategies that are mutually reinforcing of each other. And one might, again, editorialize that is perhaps part of the problem in healthcare, is that all of the change levers aren't necessarily aligned and mutually reinforcing. Perhaps the last point to note in this very quick overview of healthcare as a complex adaptive system is simply the fact that there are unintended consequences when one changes these types of systems. They are essentially unavoidable. One should anticipate that they will occur, and while sometimes those unintended consequences are positive, more likely than not they're going to be negative, which means that vigilance for unintended consequences has to be designed into the system. As far as healthcare today, what are the critical change levers that are being utilized? And I think they fall into basically these five buckets or categories. At the top of the list is simply payment reform and changing the finances of healthcare. A second change strategy or change lever is performance measurement, and I would certainly add public reporting as being part of that. Third is patient engagement or healthcare consumerism. The fourth is health information technology, not because technology in and of itself will drive change in the right direction, but it allows us to reconceptualize and rethink how we provide care. I think about it in fundamentally different ways with the capabilities that exist today with health information technology. And then the last change lever is either regulation or, in the converse, regulatory relief. The latter can be seen, for instance, with some relaxation of some of the Stark provisions that allows physicians and hospitals to operate together in ways that previously were not allowed. One might argue whether regulatory relief has gone far enough or is to the right point, but the point is that there's some steps have been taken. Obviously, there is also increased regulation being placed upon the field as well. So a few other observations about systemness. Perhaps the fourth one I would call out is that while the evidence base for how to achieve healthcare systemness continues to be quite immature and overall relatively thin, enough is known to conclude that there is no single blueprint or roadmap for how to achieve it. Instead, there appears to be multiple pathways of getting to systemness, but that systemness has a number of defining functionalities or operating characteristics. Indeed, there's at least 16 such functionalities, and I don't intend to go through all of these in any depth, but I would just quickly go through them. I think at the top of the list is simply that systemness is achieved by having a compelling mission and a shared values-based vision. Values are in many cases the compass that defines true north in times of uncertainty. And so we often don't pay enough attention to what those values that drive the vision are and how we make sure that they are operationalized in all of the policies and procedures and things that are done as we move forward. There are clearly a variety of clinical and social support and other administrative services that need to be coordinated and integrated. As was said before, this occurs by intentional design. It doesn't happen by itself. And those, in many cases, have to be operationalized within the context of the local circumstances. The strategies and plans consistently have to include frontline practitioners. I find it somewhat amazing that even today in this state, some relatively or well-known healthcare systems have embarked on quality improvement or other change strategies without involving the frontline clinicians who are going to have to operationalize that. And that is by and large a prescription for failure. Frontline clinicians have to be involved in these things. Systemness has to try to or has to achieve ready access across time and space to services, and that really has to be determined by the recipient of those services, which means in many cases we fundamentally have to rethink how we communicate and connect with patients in ways other than office visits or hospital encounters. The information and data have to flow freely throughout the system between and among all of the many pieces, and it has to be available in as close to real time as possible whenever or wherever it is needed. Service needs as another defining functionality. Service needs need to be anticipated and planned for. and particularly for the 1% or the 5% who consume the largest amount of resources, we need to anticipate those needs and design the system so that their needs are met. We need to wring out waste and try to standardize services and remove unnecessary variation whenever possible, but also recognize that there is a need for variation, there is legitimate uniqueness, if you will, and need to recognize when that's important and when standardization may not be the desired goal. Likewise, health promotion and disease deterrence and mindfulness for population health has to be integral to all services. It has to be designed into those services. To achieve these things requires strong both clinical and administrative leadership. Again, I recognize I'm going through these things relatively quickly, but perhaps another one worth calling out here is that systemness can occur either by vertical or virtual integration. Certainly one of the major dynamics underway today is efforts to employ physicians, for hospitals to acquire practices, acquire long-term care facilities, others, and to become vertically integrated. And indeed, some of the best evidence for systemness comes from vertically integrated systems like Kaiser Permanente or the VA or some others. However, I think people often don't appreciate that even those fairly vertically integrated systems also tend to function to a significant degree by virtual integration. The glue that holds together virtual systems are the data sharing and management agreements, the contracts, the IT systems, other sorts of instruments, and in many cases there are distinct advantages and reasons why one would want to pursue a virtual integration as opposed to a vertical. Perhaps another strategic or defining functionality systemness is the essentiality of having an enabling infrastructure. But I think in saying that, it's also important to point out that while an enabling infrastructure is necessary, it is not sufficient in and of itself. And I think this is where some healthcare organizations have been disappointed in their efforts to achieve systemness, is that they have moved forward to put together an IT or other technological infrastructure, but really haven't achieved the results that they hoped for. And let me just come back to that in a moment. It's probably worthwhile noting that there are at least 7 or 8 or more elements that would go into this enabling infrastructure: knowledge management and knowledge transfer systems, communication systems. These would include electronic health records and decision support systems, registries, health information exchange, a number of other things. The performance management system is another key part of that enabling infrastructure. Things such as care management, disease management tools also are part of it. Having methods for systems learning so that innovations that are attempted or the results of those innovations are continually fed back to the system. The idea of teams and team processes and the body of knowledge that goes with that. Having an agile human capital management approach, somewhat like agile software development. We need a more agile approach to our human capital assets as well. Things such as shared decision making to including patients and families, into the decision-making process. And finally, perhaps one that is often overlooked is having a participatory and structured method for balancing individual needs and preferences, whether that be patient or provider needs and preferences, against those of the system, and having a mechanism where that can be transparently, that balance can be transparently achieved, so that you get the best balance there. Just to conclude this list of functionalities or defining characteristics of systemness, as I was saying before, that the infrastructure to enable this is essential, but it's not sufficient. And I think that where we've seen the best return on investment of this infrastructure is when it's embedded in a culture of collaboration and quality improvement, an environment of inquiry, of continually asking how we can do better, and that allows these things to really operate at their highest level. Finances have to be aligned with the desired outcomes. Although it's not all about positive financial incentives, in an activity like healthcare, it may be just as important to remove the financial disincentives from doing something that might improve quality or continuity or coordination of care. And we have a number of examples today where the financial aspects are not aligned to allow one to optimally utilize things like telehealth or mHealth or some of the other strategies for delivering care that are possible today can actually be actualized. A strategic communications plan is inherent or is essential as part of achieving systemness. Likewise, the role of governance and management in the policies and procedures needs to be addressed and made clear. And finally, the last attribute here, what the evidence would suggest at this point, is the need for delivery assets to be structured in a way that they can be changed or modified as needed quickly to address changing circumstances as the healthcare market rapidly changes. I know that's a very quick overview of a lot of information. Let me just conclude with a couple of other observations about systemness that I think are relevant here, and simply that perhaps more than anything else today, achieving systemness is about culture and the culture of healthcare. And when we talk about culture, we really are talking more about sociology than technology, which tends to be where we don't often go in healthcare, or not often enough. We are very focused on the technology and perhaps don't spend as much time as we should thinking about the sociology and how do we actually change the culture so that we can take advantage of all of the technological possibilities that exist today. And then finally, the last point I would make in this regard, reiterating something that was said before, is that this culture of collaborative synergies that we talk about in systemness will only develop if the finances are supportive. Finances is the universal elixir, and we have to make sure that those are aligned if we're going to achieve the potential benefits of systemness. Let me just conclude here with this last comment that we are in the midst of a profound change. It's going to continue to change for the foreseeable future, but it's really all about how do we develop high-performing healthcare systems that are intentionally designed to demonstrate systemness, so that we have the continuous healing relationship that the Institute of Medicine talked about in crossing the quality chasm. How do we use caregiver teams and enable them with technologies that really allow us to reach across time and geography to provide services when and wherever they are needed, as defined by the recipient of those services, the patient or their family. Thank you. I appreciate the opportunity to share these thoughts with you.